Good morning and a very warm welcome to Bonitas House Corner here on SABC2. Africa Chipem, the Machero Ambud, Kerekatiba, Hutabu Hayaka. I'm Dr. Victor Ramathesele. Now, Bonitas House Call is celebrating 10 years this year, bringing you uninterrupted, interactive television talk with various experts covering a huge catalogue of relevant and topical health matters. And today is no exception, as we follow up on a discussion that we had a few weeks ago that was focusing on hospitalization, the challenges and the costs associated with it. Now, recognizing the ever-escalating cost of hospital admissions, some of the healthcare companies and investors have been setting up daycare centers where certain procedures can be effectively done without necessarily admitting these patients. And all of this is possible only because of the recent advances in healthcare and, of course, the introduction of laparoscopy, or keyhole surgery, that avoids opening up of the abdomen, joints, and other parts of the body, and the complications and the costs associated with long recovery that goes with it. Now, to explain this in greater detail, we've invited into the studio Dr. Oscar Shimange, who's a specialist obstetrician and gynecologist. We have also invited Dr. Rajesh Patel, who's head of benefit and risk at the Board of Healthcare Funders. To complete the trio, we've got Dr. J.K. Rampedi, who's a group executive chairperson of Phelang Bonolo Healthcare Group. Colleagues, we had a discussion a few weeks ago. Dr. Patel, you were here. We spoke about hospital admissions and the costs associated with it. And we also talked about how we regretted that we could not get the Hospital Association of South Africa into the studio so that they can answer for themselves some of the issues. But hey, before we get into the nitty-gritties and the nuts and bolts of the discussion, let us hear more about daycare procedures.
Daycare procedures are surgeries or procedures which do not require hospitalization and can be finished in a few hours because of technological advancement. It's very important to find out how many daycare procedures are covered by particular insurers. Some insurers cover limited daycare procedures, while other insurers cover almost all of the daycare procedures. Successive daycare surgery can be attributed to advances in surgical technologies and in the field of anesthesiology. Advances in surgical technologies that made outpatient surgery and minimally invasive surgery possible include various procedures such as laparoscopy, arthroscopy, vaginal hysterectomy, thyroidectomy, shoulder, knee and ankle repair, chemotherapy, radiotherapy, incision of the prostate, incision of the cornea, and nasal sinus aspiration, to name a few. Daycare procedures deliver the same high-quality care as that given to hospital patients and is economical as well. Daycare surgery has now become an accepted method of treatment for a number of surgical patients. All daycare surgical patients come early in the morning, and after the surgery is over, if the post-operative observation is uneventful, the patient is discharged home the same day. Patients selected for daycare surgery need some degree of focused post-operative monitoring for a few hours. A detailed explanation of the daycare surgery procedure, admission and discharge criteria, post-operative care at home by the relative, and possibility of admission due to complications, if any, is given. These patients are usually operated under local, regional, or general anesthesia. At the time of discharge, the patient's fitness is assessed, potential side effects or complications, and medication to be taken are explained.
Dr. Patel, too good to be true. And as my grandfather always said, if it is too good to be true, you must know it is too good to be true.
Very true.
Where have these things been all the time? I mean, we've been taking patients to hospital. A guy goes to do a simple, womb scrub. You admit them on the Friday, on the Tuesday. It gets down on the Wednesday. They only go home on Wednesday, and they get charged for 3 days. I mean, this, we say, procedure can be just. Where have this been?
I think we need to separate what happens in the public sector to what happens in the private sector.
Mm-hmm.
Private sector, you're dealing with less number of people that come in and out. Okay. Public sector, inevitably, you're dealing with lots of people. Okay. The inefficient systems are also, processes are inefficient to some extent. So often in the public sector, you find patients admitted on an intake day, as we would describe it. The next day, they worked up ready for theatre. The following day, they taken to theatre. And potentially the day after, they end up going home. Whereas in the private sector, with the efficiencies that have been built in, patients go in the morning, get admitted, administration processes done, into the ward, paperwork completed, prepped up ready for theatre, go to theatre, have the procedures done, recovery, go home the same day.
So you say it's a numbers game that has influenced, I mean, the efficiencies that we have seen over the years.
Numbers game, but also the processes within that hospital or that at the clinic.
But private hospitals have been accused on many occasions of alleged over-servicing, that patients that could have stayed 2 days in hospital are made to stay 3 days or even 4 days. Your views on that?
I think the important thing in the private sector is to understand is that the doctor makes the decisions of how long patients stay in hospital. And not necessarily the hospital. Obviously, the hospital make money the longer a patient stays in the hospital and the amount of work that needs to be done. And I think that's the critical component, is the doctor is a key player in what happens in hospital. Whether you go into hospital and when you're in hospital, what gets done. They're the key decision makers.
Now, Dr. Shimanga, your group has been in existence. It's called Cure Day Clinics, is it?
Cure Day Clinics, yes.
It's been in existence for how long?
It's now on its 9th year.
Okay. Now, since you've started, obviously, you're getting more and more doctors referring to your hospitals for daycare procedures on some procedures that were previously done through hospitalization. Would that be correct?
Yeah, that's quite correct, yes.
And what has led to the influence or the more usage of your kind of facilities over the years?
There have been a lot of changes. The first change which actually happened is the efficiency of the anesthetic agents and anesthetic machines. With new drugs nowadays, a patient recovers immediately, the procedure is finished. And they've got less after effects, which we used to get with the old anesthetic agents. That's the first thing. The second thing, with the advance of technology and skills, many procedures which in reality in the past used to be done with what we call open procedures can be done with minimally invasive surgery where you don't have to actually cause too much trauma. And then the next thing is that most of the patients nowadays come from areas which are within reach of the facilities. While in the past, health facilities were so remote, at times you have to take about 3 buses before you actually reach a health facility. So after being operated, if you have to take the same transport again, it becomes a problem. And of course, modern medicine has actually advanced that things can be done far much safer without invasion into tissues of the patients a lot.
I mean, in the olden days, even when you're doing a procedure like a removal of the appendix, which is appendicectomy, I mean, you would have to open and cut and remove the appendix. Now, these days, you do that by keyhole surgery, am I right?
That's quite correct. A patient can have an appendix removed. If there's no evidence of sepsis or it was not ruptured, the patient can actually be discharged about 4 to 6 hours later.
And yet, in the olden days, it would be a few days before a patient is actually, because then you'd have had to open, you must deal with the wound, you must deal with the anesthesia that has taken a long time and all of those things. So all of that has been eliminated by introduction of the keyhole surgery, as we said, and some of the newest anesthetic methods where you can put them to sleep, do the procedure, get them to wake up, and hamba kaya quickly.
Another interesting thing is that in the past, with open surgery and patients being bedridden for a longer time, it used to actually increase the risk of complications
related to the surgery.
Things like deep vein thrombosis, which I mean, you'll be told that you can only start walking around 5 days after the operation. And people used to get so sick and we didn't know what is the reason. Just to give for an example, a patient can come with a ruptured ectopic. If the patient is still hemodynamically stable, you can do the procedure, and then 4 hours later, that
patient can go home.
Can go home, yes. That's what we're doing.
Interesting stuff. Now, Dr. Rampedi, you have a hospital group. Now, in your group, do you do daycare procedures only, or do you do daycare procedures and admissions? Because the next thing that I was going to ask is the association between the two types of services.
Yeah, we in our group, at the moment, we've got acute hospitals. But within the acute hospital, you do have the day beds.
I see.
So you've got a portion where it's reserved specifically for the day procedures.
I see.
Even though the hospital as a whole will be licensed or will be termed as an acute hospital.
What is an acute hospital, just for the sake of those people?
Basically, it's a general hospital.
Okay.
You know, where you can be admitted and stay a number of days. Okay. Obviously, you stay there because, one, the doctors decided that you're going to stay 2 days because he needs to do investigations. You probably need some few drips. And if you talk about procedures, you probably need a much longer procedure. And aftercare of the whatever surgery that has been done on you needs a few more days. But we are cognizant of the fact that others they just need a day and they must go. And as my colleagues have already described.
This is quite interesting because, I mean, it saves costs, it saves time, it saves the resources. I mean, it just says, that's why I say it is too good to be true. But what do you need to have in place? What does it save again?
There's a problem there.
Where's the problem?
A lot of this advances has taken place because of new technology that comes in. But the cost of the new technology is not necessarily affordable.
I see.
And I think often what you find is when you do analysis of the inpatient open procedure relative to the day procedure, you find because of the cost of the equipment that's used and the technology that's used, it's really exorbitant. And they're either same price or very close to each other.
So you've got to strike a balance somewhere.
You've got to strike a balance between the two.
Dr. Shimage, just before we go to the ad break, what are those things that you need to have in place before you can say, I am ready to do daycare procedures?
You see, day hospitals actually were in existence in South Africa long ago, but it was taken as substandard type of facility where people used to make their hospitals probably in garages and so on. And this is what led to the fall of their hospitals.
I see.
So our approach presently, I'll specifically mention in our facilities as care day clinics, we don't compromise on standards and also on technology.
I see.
Just to add on technology, unfortunately, because of all the R&D which is done with technology, technology is
research and development. Let's unpack R&D.
Or research and development.
Yes.
But what we have to look at with the use of technology, is there any benefit for a patient? And the answer is yes. And this is what we are actually looking at.
Okay.
Because, you know, the problem with trying to contain costs, you can contain costs up to the extent that you compromise the benefits which the patient is going to have. Just look for an example. Technology can be expensive. If somebody comes with a ruptured ectopic pregnancy and I do a laparoscopic procedure and that patient goes home the same day, it saves a lot on hospital stay for the next 3 to 4 days. These are things which you need to factor in.
But it has to be done by somebody who's experienced, and you have to make sure that should anything go wrong, you've got the ability to deal with it and everything else. But we'll come back to that detail after the break. We'll continue and hear more about daycare procedures. Stay with us. Mzikaba awufikanga ugadalekile sibamba ngazimbini futhi sihlabela mgama ke ngarodlo nohlebe ke namadoda abazikazulu ke ngocwangciso nokwenza uqhaqho lomuntu ungakhange angeniswe esibhedlela elithwa ku daycare procedures ngolimi lasemzini. Sitswana siyatle sare more mogolo go betla wa taula wa motho wa ipitla. Now let's talk about all of this now. So somebody somewhere, Dr. Rampedi, will make a determination that this is the list of procedures that can be done safely at the daycare procedure. And for this, funders or medical aid schemes, or whether it is the road accident fund or the compensation fund, or whoever funds healthcare services will agree to pay. Is there a standard somewhere that is set so that we don't get Dr. Shibange trying to do things that may not be safely done in a daycare center and maybe and land into trouble or something? Is there a way of guaranteeing that?
Yeah, no, definitely. I mean, the service providers, which will be the doctors and the funders, who will be informed by evidence-based research to say these things can be done safely in a day clinic. They come to a conclusion and agree that these things this scope can be done in a day clinic. It is not random.
Okay.
It is evidence-based.
And when they have a new procedure, when Dr. Shimanga and his crowd of obstetricians and gynecologists, that they have a new procedure that they have developed, or a new way, a novel way of dealing with a particular procedure because they have a new equipment, that do they have to apply to somebody and somebody must assess it and agree that this can be standardized as a process that can be done in a daycare center?
Look, they have to give information to say these things, this particular procedure has been done before, laparoscopically, and there must be numbers given and evidence, given, and the funders will look at it, because even within the funders, there are doctors of the same caliber who will be able to ask the right questions and get the right answers, and ultimately it's a consensus to say, yes, these procedures can take place in a day clinic or day hospital. It is not random.
I see. Yeah. I don't want the viewer to get an impression that we are only talking about operations when you say procedures. Other than operations, what are some of those things that were previously done through hospitalization that can now be done in a daycare facility?
Operation is one set of things that's usually surgical. There are medical reasons for being admitted.
I see.
A typical example would be cancer patients going through for chemotherapy.
I see.
They often need a bed. They need to have infusions put through them. The other examples would be blood transfusion, for example. Some patients might need. You don't need to stay overnight. Come through in the morning, get your blood transfusion, couple of hours, wait to see that you're not having any problems, and that's it. So there are other reasons for being admitted as day cases instead of just operations. You also have certain investigative procedures that can be done, not necessarily requiring theatre. It might require a side room or a procedure room, like a gastroscope, for example. So you'd often have those coming through as day facilities. Most often in those, doctors have their own side rooms. Some doctors don't have those facilities, then they'll make use of a daycare facility.
Okay. I did ask a question a little bit earlier, and I didn't really get a proper response, in my view, on this, that what do you need to have in place before you can start doing daycare procedure? Obviously, you need to have a very experienced and efficient anesthetist who's going to do all of these, anesthetic procedures, and who's going to be on standby should anything go wrong with a patient by way of a medical emergency or something like that. But what else do you need to have in place before you can start doing daycare procedure?
Day hospitals are actually built according to the requirements by the Department of Health, where they need to have basic facilities. The only difference between a day and an acute hospital is that, for example, you don't need to have a kitchen because people are not going to stay overnight and they need to be fed. But you need to have theaters with state-of-the-art equipment ranging from anesthetic machine, good gas infrastructure, things to resuscitate the patients, a good recovery area where patients can be recovered. And then after they've been recovered, then you need to have beds where they can be admitted for that time immediately after the procedure. The only difference is that they don't have to stay overnight. Staff-wise, you need to have qualified staff. They will dictate to you, if you have got, say, a 30-bed day hospital, how many qualified nurses of this category do you need?
So your license will come with all of those conditions?
Those are the conditions which, even when they come and do inspection, before you can actually open the facility, you need to prove that you have got all those things.
Now, Dr. Ramathesele is sitting in a much favorable position because his facilities, you have an acute facility and an area that has been carved out to do daycare procedures. Now, I'm just asking, in case that we're not like, do you need to have an ICU just in case something can go wrong with a patient? Is that a necessity?
No, from the acute point of view, we do have an ICU. You have to have an ICU.
But for a daycare facility, do you need to have an ICU, or there's always a view that you can transfer that patient to an acute hospital where there are ICU facilities?
Of course, the daycare or the day hospital must have some relationship with an acute because some other complications are unpredictable. Should that happen, you should have a means, you should have the systems must be in place such that you can transfer to an acute hospital to can give you support.
I see. Yes. Who makes the decision that this patient will be treated at a daycare facility as opposed to a full hospitalization?
It's the doctor treating the patient depending on the condition of the patient and the kind of care required for the patient. If the type of care the patient requires is an overnight stay, or as you suggest, an ICU, which also requires overnight stay, then it would go to acute care, acute hospital, acute bed hospital. If he feels the patient has a nature, the problem is such that the procedure or whatever intervention they consider can be done as a daycare procedure, go in, have the procedure done, go home after that, then they're the ones who make that decision and that call. Naturally, their decision is based on their knowledge and experience on this type of thing and published literature that informs how they should provide that care.
Before we come to some examples of some of the daycare procedures that we do, which we'll do after the break, Dr. Shimang, would there be a certain type of patient maybe that wouldn't encourage to even consider daycare procedure, maybe because of their condition?
Yes, actually, when you treat a patient, you need to individualize, and you also need to look at risk factors. I just want to give you, for an example, I've got two patients who I need to do a laparoscopic procedure. One patient weighs 120 kilograms. The other one weighs 70 kilograms. Definitely the patient who is weighing 120 kilograms with high blood pressure and asthma is a high-risk patient. So that patient can be done as a day procedure. That patient will have to be admitted to an acute hospital. And the same procedure will be done in an acute hospital. But you might need to admit that patient before to evaluate and after to observe whether there are no complications or anything. So you need to individualize. And this depends on the clinician and also the day facility where all those things are done. We have got sort of standards and ethical committees which will actually look, because if you start doing procedures which can be done there, it might have a big impact.
Then the patient is actually sick, but the patient can't make the decision.
And you have to look at litigation.
Oh, we're coming back to that. It's a subject that we discussed a few weeks ago, and I was actually going to bring it. Don't steal my thunder. When we return, we'll continue our discussion on daycare procedures. Welcome back. Watching Bonitas House Call here on SABC2. And today we are discussing daycare procedures. And with hospitalization contributing so significantly to our soaring healthcare costs, there's absolutely no doubt that medical schemes and their members will be more than happy to support and embrace these initiatives. Let's watch.
Procedures carried out at the daycare facilities are charged at a significantly lower rate than hospital facilities. Overnight stays are also avoided, and this has a significant impact on reducing hospital costs. The average difference in cost between surgery performed in a daycare clinic as opposed to an acute hospital is in the region of 10%. Daycare surgery is at least as safe, if not safer, than the surgery performed at the hospital, while there is no difference in the quality of care provided. Our experience is that patients generally prefer to use daycare centers due to the convenience. There are no disadvantages to using daycare centers. Daycare surgery covers a wide spectrum of surgical procedures, from minor operations under local anesthesia to more major procedures under general anesthesia. It is also suitable for a broad range of surgical specialties. Over the past 12 months, procedures for cataracts, followed by circumcisions, tonsillectomies, and adenoidectomies accounted for 35% of Bonitas daycare surgery cases. Currently, Bonitas pre-authorization procedure for an acute hospital is the same as that used for a daycare clinic. Members should apply for a pre-authorization reference number as soon as a procedure is planned, ideally 2 days before the date of admission. This is done via Bonitas Hospital Benefit Management Call Center or by email. All pre-authorization requests are evaluated against the scheme rules and clinical finding policies, and once authorized, members will receive a confirmation letter. Members should make sure they read and understand the letter and speak to their doctor if there are any questions.
Wow, there we have it. Very, very interesting when you look at the costs associated with this and how they can contribute to maybe trying to manage the healthcare inflation in this country. But let's talk about, Dr. Shimank, in your setting now, what are some of the commonest procedures that you perform as daycare?
I'll try and go through different specialties. Let's start, for an example, with gynecology, which is actually my field. You can do diagnostic laparoscopies, you can do ovarian cystectomies, you can do excision of endometriosis.
Hang on. You see now, you need to explain what these things are, because just mentioning it by name is not going to have. So laparoscopy, what is a laparoscopy?
Laparoscopy is what we call minimal invasive surgery, where you use buttonholes to actually do procedures inside the patient's abdomen.
While you are standing outside.
While you are standing outside and looking at a television screen without making big cuts on the patient. You can probably make about 3 or 4 cuts about 1 centimeter long in different positions.
And when you are done, the operation is done, and then you just have to close those small holes, and the patient is there, can go home within the next few hours.
Yes,
as opposed to cutting out and working
that's
from
quite correct.
Okay,
yes, yeah.
So you can do quite a few procedures. In gynecology that you can tie the tubes, you can remove certain things, and what else can you do?
You can also do hysteroscopies where you look inside the womb.
I see.
And then you can also operate for diseases inside the womb, like removing growths, removing polyps, which are small pimples inside, and you can even correct some of the congenital things where patients are born with what we call uterine septum and so on.
Okay.
And then also you can do things like Shirotka sutures, where the cervix is not strong enough to maintain the pregnancy, and then you need to strengthen it with a stitch.
Or where you have cervical incompetence, in other words, where the neck of the opening of the womb opens up too early and can let the pregnancy out, so you need to close it to keep the pregnancy inside.
That's quite correct.
So all of that you can do as a daycare procedure.
And also many external procedures like removing of the Bartholin cysts and excision of other small growths which affect the female genital area.
Let's hold it there. Let's hold it. Now he started with gynecology, which is his specialty. Dr. Ramathesele, when it comes to orthopedics, what are some of the common procedures that can be done at a daycare facility instead of hospitalizing a patient for a few days?
Yeah, they can do some reductions of small fractures. They can look into the knee, you know, with instruments.
Arthroscopies, keyhole surgery also.
Yeah, keyhole surgery. You know, there's just a number of them that they can do.
And the shoulder, which used to be my area of specialty when I was still a sports physician. So even the shoulder procedures can be done.
The shoulder procedures they can do at the day clinic.
What are some of the newest ones? And Dr. Shimanga indicated earlier that as they develop, you know, more and different ways of doing things, they have to apply to you as a funder so that you can agree to pay for those procedures should some of their patients be members of the medical schemes that you administer. So what are some of the newest ones that have come to the fore in recent months or in recent years?
Oh, now you're challenging me. Some of the ones that are the surgery on the heart, there's spinal surgery that's being done, keyhole surgery. Now, obviously, those, I think, it's still very early stages, and I've seen quite a few of them with overnight stays. But I think we're getting to the point where those procedures would probably become day procedures, whereas before they used to end up staying a whole week. I think the other important one that we've seen a lot in the US is laparoscopic cholecystectomy, where they take out the gallbladder. There it's done as a matter of routine as a day case. South Africa seems to be different. We definitely need overnight stay here.
Is it?
And I think that's probably a difference in practice and maybe people's training. But this is something we need to work towards, that if it can be done as a matter of routine in a country like the United States, then we should be able to work to similar levels here in this country as well.
In the eye, I've seen quite a lot of eye clinics popping out here and there here in South Africa and doing a lot of procedures as daycare procedures. In the eye, would you say the majority of eye procedures
almost all eye procedures are actually done as day procedures. Yes, almost all of them.
Even removing a cataract?
Yeah, that's actually the commonest, which is done as a day procedure.
So any ophthalmologist worth their salt should be able to do these things at the daycare. They just need a good anesthetist and then they're good to go.
Yeah, I think with eyes, most of the procedures are actually done under local anesthetic.
Yeah. So you don't have to put those patients to sleep?
No.
Okay. Now, you mentioned quite a few procedures in gynecology because you're an obstetrician, gynecologist, and Dr. Ramathesele gave us a sense on what happens in orthopedics. In other disciplines...
Let's go to ear, nose, and throat.
Yeah.
Tonsillectomies.
Removal of the tonsils?
Yeah. Grommets.
The small
things they put in the ear, yes.
Through the eardrum.
Correction of the nasal septum, nasal polypectomies, adenoidectomies.
Okay.
Yeah.
So removal of the adenoids, removal of the tonsils, all of that. Daycare procedures done. Hambakaya.
That's what actually
in children
happens.
as well?
Yeah. With children, you have to look at the age of the children. Normally, we don't recommend doing day procedures if kids are less than 5 years for good reasons, because the type of anesthetic which they get might be a bit more specialized, and if you have got a problem, you might need to observe them a bit more. But after that, most of them are done as day procedures.
Do you want to tell me that a lot of the procedures, especially cardiothoracic, where people used to be opened up with a sach and open, that some of them now you can avoid opening up the chest and actually doing them as a daycare
There is keyhole surgery being done for those procedures. And while this is encouraging, as I mentioned earlier, the devices, equipment, etc., that's required is expensive.
So
but it's understandable.
Are you suggesting that in the final analysis, not all daycare procedures are going to be cheaper than if you have admitted the patient, but if you look at the cost in the long term, that some of them might actually be more expensive in doing, but if you look at that, the patient is going to stay less number of days in hospital, that complications are going to be that. In the final analysis, it is cost effective.
It might be cost neutral, but obviously you're staying a shorter duration in hospital, and it might speed up recovery. So that's still a win-win. That's still a win in that situation. You're still winning. I think the important thing we must recognize, bypass surgery before people used to stay almost a month in hospital.
Oh, that's for sure.
Right now, within 4 or 5 days, people are out of hospital. And that's huge leaps in technology that's allowed us to do those type of things.
Now, speaking about technology now, would you say only costs will be the restricting factor in us in South Africa getting, access to the best technology there is in the world, or you guys who are in the field have got other things to consider? If one buys a machine, that is the required number of patients to make it profitable, or what are some of the things that govern the extent to which us as South Africans can actually get access to some of this, technology that is fancy and that is innovative?
Yeah, look, technology it's something that we require. It's something that is the best thing to do, but it also goes with expertise to operate that technology. So it's well and good to have all the technology, but we still have to get people trained to use the technology.
I see.
Because it can be, it can also create a problem if it's not operated by people that have been trained properly to use that same technology.
Which brings me to the question that you raised a little bit earlier, Dr. Shimanka. Now, if you've got all of this fancy equipment and they are available in daycare centers, and daycare centers are not typically structured to provide teaching and training, how then do we ensure that some of the people who have been trained as registrars and consultants and specialists in the public hospitals actually get access to some of the fancy equipment that is available in your centers and may not be available in the public sector? How do you ensure that happens?
I'll just give you an example. Cardiac surgery, open cardiac surgery, pediatric cardiac surgery in the Western Cape as early as in the early 90s was only done at Christian Barnard Hospital because there was Dr. Foslo who used to do it.
Which is a private hospital.
Which is a private hospital, but the registrars used to rotate.
I see.
Yeah, it brings us to something which I think is unavoidable in South Africa.
The collaboration.
Where you'll have to get collaboration of private facilities and academic hospitals. Because whether we like it or not, skills are very scarce in the public sector. Most of the skilled, trained people are in the private sector. So they need to actually get involved. I mean, we see a lot of specialists and super specialists actually operating with their registrars in private practice so that they can learn those skills.
Because even some of the equipment is not available in the public sector. So we'll talk about the collaboration between the two after the break. We'll continue our discussion on daycare procedures after the break. You stay with us. Welcome back. Maneso, Satswa Pelaka Saletsa Timona Bonitas house call SABC2. And today we are talking daycare procedures. Dr. Ramathesele, we can see the benefits, the advantages of performing some of these procedures. And we all said it's not only operations, sometimes it is forms of treatment, sometimes it is investigations and tests where we can avoid patients staying in hospital, hospitalized, and we can do these things in one day and the patients can go home. Now, the NHI paper is still going to come out sometime this year, hopefully, touch wood. It was supposed to have come out last year already. But what do you think is a possible role that daycare hospitals such as Dr. Shimanga here runs and such as some of the facilities you have in your own setup? What role do you think they might or they are likely to play as a national health insurance force?
Look, in my opinion, I think there's a major role that they can play. Because remember, we are trained basically from the same premise. I mean, a patient is a patient. And we are committed to the patient. It doesn't matter whether you're in private health care or in public health care.
It doesn't matter who pays.
It doesn't matter who pays. The important thing is that the patient must get well. That's our whole game, you know. So for me, whichever way that is structured, we know practically we have to help government. We have to take initiatives. So there must be some collaboration of some sort to say, listen, we look after so many patients. We've got so many facilities. The queues are not going to get better. The people that need those services will always be there. So I think it will be logical for me to say, listen, with the facilities that you have, with the skills that you have, with the technology that you have that we might not have, or whether they have or not, is to take some backlogs, you know, and that will advantage the people. That's the bottom line.
Because we all know that when it comes to elective procedures, in other words, those procedures that are done not as an emergency, such as cataract removal and some of your knee replacements, hip replacement, that in the public sector, I mean, there's a long waiting list, you know, for patients to have that done. When in fact, some of these facilities can be made available, you know, to cut out the queues, and some negotiation can be entered into with government on how to remunerate, you know, specialists who are working in that area in the private facilities who can provide this. So hopefully with the discussions and the national health insurance coming through, we might begin to see this happening, and then only the patients will benefit in the final
analysis. Only the patients will benefit. And in the countries where universal coverage has been, I haven't seen anyone where it was achieved without collaboration of public healthcare and private healthcare.
Because, well, at least in South Africa, as matters go, I mean, both of them are not sustainable, I mean, working in silos. So at some point, circumstances are going to force some form of collaboration. So hopefully, we can get that collaboration without being forced by circumstances, because when that happens, things can be very difficult to deal with. Would you say these daycare procedures, notwithstanding that you are saying some of the equipment used, and Dr. Shimang and the crowd, sometimes they can overcharge. There's issue about specialists and private hospitals that the market inquiry is busy with. You are not going to enter that. But would you say, since their introduction, and certainly during their mushrooming, as we can see now, that it is beginning to have an impact on health inflation?
Difficult to say that right now. I think you still need a lot more day clinics, daycare centers out there to really make an impact, because the number of clinics you have is very few and limited. I think there's about 30, 40 day clinics, daycare centers, 45, compared to a couple of hundred that you have of the acute bed hospitals. So you need a lot more out there, but the problem in South Africa is most of them cater for the private sector, and the private sector is just 8-9 million people. So you can't keep building all this infrastructure hoping that it will sustain them. But I think going into the future, the public-private partnerships, that can utilize a lot more of the spare capacity you have, and you can then bring in a lot of the efficiencies that, and I'm sure that will help the both systems.
Now, I realize there's a Day Hospital Association of South Africa. I would suspect that your entity, your company, is a member thereof. How does that work, and what is the role that it plays in ensuring that we can achieve the economies of scale, as Dr. Patel here
presently, because of the number of day hospitals, they still fall under the National Hospital Association. That is for basically for setting standards and tariff negotiations. But there is a Day Hospital Association which has recently been formed. We actually contributed to the reactivation of that, so that in future, once we have got enough day hospitals, then we can sort of have our own sort of negotiating platform.
Because you have to go and negotiate with Dr. Patel here and how much they must pay you for these procedures and all of that. And you need to have that standardized, because it can't be left to the devices of the various specialists and on how much they should charge, right?
No, that is not actually left to the specialists, because the NHN actually has control over that.
I see.
Yeah, but it's difficult. I think it's difficult for the NHN to look both at acute and day.
I see.
Yeah.
So day hospitals, at some point, will have to be an independent organization that looks at the
numbers,
unique interests.
As the numbers increase, yes.
Very interesting. So whoever I see listening out there, especially these people who must provide licenses, they just have to understand that there's a need for more and more of these day facilities. But sesifikile-ke sonke la kwelikamthanyaka obuchwepheshe nobunoningcobo okwenza uhlinzo lolu esikhuluma ngalo olungadingi ukuthi isiguli silaliswe esibhedlela size sisikwe kuvule isizwe. Sesimane sibhoboze nje kancane la enkabeni, sibuke ngekhamera, sihlinze, sime ngaphandle. Baqedala usukudedela emva kwamahora nje ambalwana ukuthi uhambe ugoduke uye ekhaya. Sopholile kanjalo. We'll run up our discussion on daycare procedures when you return. Watching Bonitas House Calling here on SABC2, and welcome back. We are rounding up our discussion now on daycare procedure. I think the advantages are very clear for everybody to see that we still need to have more and more of them out there. We still need to control how they are licensed, that they adhere to the conditions of the license to ensure that they remain safe, they remain efficient. And of course, we also need to guard against the pricing of some of the equipment and procedures that they do. But there's no doubt that daycare procedures are here to stay, and they are going to change the landscape of healthcare provision in South Africa. As a funder of some of these things, Dr. Patel, what would be your parting message?
I think the important thing is daycare procedures need to be separated. Those that need theatre and facilities, those that can be done in a side room, either next to the doctor's rooms or side room in the clinic, and importantly, done on an outpatient basis. Procedures like circumcisions can largely be done in the side room, not necessarily in theatre and those type of circumstances. There's quite a few other procedures that can be done under sedation in the side room. So it's important to distinguish these day care procedures as one that requires anesthesia in hospital, in theater, to ones that can be done in the doctor's side rooms. And I think the ones that can be done in the doctor's side rooms, we must encourage that even a lot more. And not necessarily admit in a hospital or in a daycare facility. And I think we need to start moving away from that component as well.
Okay, so for that to happen, Dr. Ramathesele, it means a lot of general practitioners will also have to be trained in doing some of these things, you know, even in their rooms as daycare procedures, without necessarily taking them even to a day hospital, as Dr. Shimanga will have.
Yeah, no, definitely, I agree. And if the general practitioners start to do that, definitely the cost will be brought down, and it's clear that the day clinics will also contribute towards cutting down the cost of healthcare. And as he has said, it's important to define those procedures that can be done safely in the doctor's rooms, and those that can be done over a day, not over 24 hours in the day clinics, and those that need to go to hospital, well defined. And I think we all on our way.
Dr. Shimanga, from here, where to with day hospitals and daycare procedures?
What I'd like to clarify is that there's that belief that day hospitals and acute hospitals are competing, and it's not true. I think they are complementary.
They are complementing.
It's better to have a bed at an acute hospital and admit somebody who has got a cardiac problem than to admit somebody who's coming for a tonsillectomy, because there's a problem with shortage of beds. Another thing I'd like to comment on, having been a clinician who has done procedures in the office, is that point number one, skills are a problem. And if you have to do procedures in your office, one of the requirements is that you must have full resuscitation equipment, which is actually not happening, and I don't think is really being supervised. You can give a local anesthetic and the patient can go into an anaphylactic reaction. If you don't have that, then you lose that patient. So for everybody
who wants to do your procedures in your rooms,
that is the requirement. That is the requirement.
But I think Dr. Ramathesele, in another guise, I think they spend a lot of time and a lot of resources to ensure that general practitioners are actually equipped. And we can hope that with the passage of time, it will be done not only in the private sector, but even everybody who's a doctor when they assault could be trained in this regard. Guys, I think we've done well in trying to unpack the subject. I'm sure we'll go back to it. And of course, as we discuss many other procedures, we'll always bring back the daycare element to it as we go along. Dr. Shimanga, Dr. Patel, Dr. Ramathesele, thank you very much for having joined us this morning. And I'm sure we'll go out there and promote daycare procedures wherever it is necessary. Banabes, rona bohle ba hui ka ba lona beng ba lena lena rona re timane ka ditaba e se dipabi ba nnete ke ya moroho le tswa ke ba ke science go le kana tsa tsena ka jene. We'll be back next Saturday with one-on-one with Dr. Precious Moloi. Don't miss this one. Here on SABC2 at 8:30 in the morning. Thanks for joining us today. And from me, Dr. Victor Ramathesele, take care.